Good afternoon, everyone. We are now live.
Great. Thank you so much. Well, it's my honor today to welcome you to our first advisory council meeting of 2023 and the first of a new 2-year term. My name is Colleen Elstermeyer. I'm the Deputy Executive Director of the Health Policy Commission. It's my honor to kick us off today, to kick off this term. Welcome to our advisory council members, both our new and our returning advisory council members, and also to our designees that we have here today. And also, of course, welcome to all of those watching on our live stream on the HPC's YouTube channel. Thank you so much for tuning in. We have really a great agenda today to kick off the new 2-year term. I'm expecting a very exciting discussion of all the hot topics and issues and challenges facing our healthcare system today. We just have one main agenda item where Executive Director David Seltz, who's joining us today, will present for discussion the agency's priorities and agenda for the first half of 2023 for your input and feedback. Before we get started, though, I do want to introduce our Executive Director, David Seltz, and the chair of our board, Deborah DeVoe, who's joining us today. I don't know if I saw Deb sign in yet. When Deb arrived, I'm going to have her introduce herself to you all, but thrilled to have her join us today for our first advisory council meeting. Before we get into the discussion, as we are at the start of a new advisory council term, I do just want to orient our new members and anyone tuning in for the first time to the role and purpose of the advisory council itself and how it supports the mission of the agency. So let's just go ahead and turn to the first slide. As you all know, in 2012, Massachusetts became the first ever state to establish a health policy commission, any body of its kind, and also establish a target for sustainable healthcare spending growth. Since then, and we're so proud to say, there are now 9 states with healthcare cost growth targets or emerging regional cohorts that are solely focused on cost containment efforts. So that's huge progress across the country. And, of course, many of you know 2022 was a very special year for us at the HPC. We celebrated our 10th anniversary as an agency, exercised some of our most important statutory responsibilities for the first time. We got a new board chair. And the 10-year milestone really gave us a chance to reflect on our work and our priorities and our agenda moving forward, a big part of which is our advisory council. So on the next slide, reflecting on that, the HPC's mission has evolved over the years as well. The HPC's mission is to advance a more transparent, accountable, and equitable healthcare system through our independent policy leadership and innovative investment programs. Our overall goal, better health, better care at a lower cost for all residents across the Commonwealth. In the past couple of years, we've added the words in orange, really important words, to reflect this evolution of the agency and of our mission. And on the next slide, the role of the HPC, how exactly do we do our work? How do we work towards that mission and goal? We employ 4 core strategies to help realize our vision. It's market monitoring, it's research and reporting, it's convening, and it's partnering, all of which our advisory council supports. On the next slide, just taking it up a level, how does this all fit together? The HPC has an 11-member board of commissioners. We've got 5 gubernatorial appointments, 3 appointments from the Attorney General, and 3 appointments from the auditor. All board members are appointed to 5-year terms, and they all fill different statutory slots, as you'll see on this slide. The board is overseen by our chair, the staff is led by our executive director, and the advisory council is appointed by the executive director, so a separate entity altogether from our governing board of commissioners. And then finally, what's the role of the advisory council? One of the first things we did when we started the HPC 10 years ago was appoint the advisory council. There was no prescriptive timeline in law, but we sat down and did it as the first thing. It was so important that we convene this body almost immediately. And we do revisit membership every 2 years since then. And today, of course, is the first meeting of the new term, 2023 to 2024. Listed on this slide is explicitly how the advisory council supports the agency's work. The goal is really to gather input on all the work of the agency, our research agenda, our investment agenda, our policy agenda, through discussion of issues and challenges that you're all facing. Also serves as a real network, a real communication pathway between the advisory council and the staff and the board of commissioners. A lot of that happens offline outside of the four corners of the advisory council meetings. For the new members, we absolutely will be hitting you up outside of the 4 meetings that we have per year. So watch out for that. Which brings us to our next slide of our incredible new slate of advisory council members. So this year we appointed 34 members representing all aspects of the healthcare ecosystem and beyond in Massachusetts. So we have labor representatives, we have consumer disability, other advocates, we have health plans, we have providers from across the care continuum, we have health equity experts, we have people really working in our communities, we have our local pharma and biotech leaders, we've got business leaders, we've got policymakers, and we've got, of course, our other state agencies with whom we work very, very closely throughout the year. We worked extremely hard this year to expand the diversity and voices and perspectives of the advisory council members. On this slide, full membership list. I am not going to introduce you all today, and I'm sure you're all grateful for that. But if and when you do have a comment or question today, please do introduce yourself, your name and your organization just before you start. When you do have a comment, raise your hand, and either I or Director Seltz will call on you. I keep a long queue throughout the meeting, so just hop on in and we'll absolutely make sure everybody who wants to has a chance to speak on any topic. And just a reminder, the raise hand button is on the bottom menu of your Zoom screen under the reactions tab. So just take a look out for that. But for our 10 new members, I would like to ask each of you to introduce yourselves briefly, and I'm going to go in alphabetical order. And we're actually going to take down the slides and move to the speaker mode for the folks that are watching on the YouTube so they can see who's presenting. I'm actually going to start with Amy Brewer. Amy, if you could kick us off with intros, would really appreciate that. Welcome to the Advisory Council.
Thank you. I'm really glad to be part of it. I'm Amy Brewer. I'm the president and CEO of Sturdy Memorial Hospital. We're a health system down in Attleboro, Mass. Thanks for having me.
Great. Thank you so much. And Dr. Callahan, can you go next?
So I'm Jeanette Callahan. I am a general pediatrician at the Cambridge Health Alliance, practicing for God too many years at this point. Also serve as medical director of a DYS Justice Resource Institute collaborative, basically providing healthcare to justice-involved youth in the Northeast region. And I'm delighted here, and I just have to say that I was part of creating the HPC. I'm so proud to be able to say that through my work with GBIO 10 years ago, and just delighted to be back in the loop and with a bunch of amazing folks. I've just been looking at each of you and seeing what a wonderful group I'm with. And so I look forward to adding something to this conversation.
So great. Thank you. Welcome. Next, we appointed Tariq El-Sawe, who's the president of Optum Northeast and Midwest. But he is not here with us today, but we do have Jonathan Chines, who's the VP at Reliant. Sorry, Jonathan, I'll let you go ahead and introduce yourself.
Sure, no problem. So I'm not Dr. El-Sawe. He's not to be here today, but sends his apologies. I'm Jonathan Chines, Vice President of Payer Strategy and Contracting at Reliant Medical Group, and in that role work very closely with Dr. El-Sawe in his role as both President of Optum's Northeast region, as well as Chief Executive Officer of Reliant. So within Massachusetts, Optum incorporates both Reliant Medical Group and now Atrius Health as of early last year. So glad to be with you today.
Thank you so much for joining us. Very excited to work with you. Next, we have Eric Gulko, who's our new broker representative. Eric?
Thank you, Colleen. Eric Gulko, founder and president of Enobo Benefits Group, an employee benefits brokerage firm headquartered in Massachusetts. Also, Vice President, Legislative Chair for the National Association of Benefits and Insurance Professionals. Just want to say I'm very honored to be part of this group, and not only to be able to maybe add a voice for Massachusetts, but also recognizing what we do here is considered thought leadership for the rest of the country. So thank you for having me.
Great. Thank you so much for being here. I don't see Susan Hernandez. That doesn't mean that she's not here. Susan, are you here?
I am.
Oh, great. Welcome, Susan.
Thank you for having me. So I'm Susan Hernandez. I am a clinical director in adult integrated care at Mass General Hospital, but I'm also a practicing nurse midwife of 23 years, and I'm the legislative co-chair for the American College of Nurse Midwives here in Massachusetts. And I'm delighted to be here today. Thank you so much for having me.
Excellent. Welcome. And then next, Juan Lopera from Beth Israel Lahey Health. Juan, welcome.
Hi, good afternoon, everyone. Thank you for having me. I'm Juan Fernando Lopera. I'm Chief Diversity, Equity, and Inclusion Officer at Beth Israel Lahey Health. It's nice to see a number of familiar faces, friends, colleagues here. I'm also one of the co-founders of the Health Equity Compact with my good friend who I know has been a member of this council, Michael Curry. Good to see all of you. Thank you.
Welcome. Thank you so much. And of course, Tish McMullen, head of COBIT. Tish.
Thank you, Colleen. Tish McMullen, Executive Director of the Conference of Boston Teaching Hospitals. And Colleen, I'd be remiss if I did not give a big shout out to our hospitals and all the hospitals throughout the Commonwealth for their response yesterday to the hospital evacuation in Boston. Takes a lot of work to have a seamless transition of patients in that situation. And it was just really wonderful to see them all coming together. So hats off to them, hats off to the EMS and first responders that did so well in that situation. Thank you.
Thank you so much. Welcome, Tish. Appreciate that. And now we have Nicole Obi from BECMA. Nicole?
Hi, everyone. Nicole Obi. Coming off of a bit of laryngitis, so excuse this squeaky voice. I'm the president and CEO of the Black Economic Council of Massachusetts. We're a statewide organization that does advocacy as well as provide support to the Black community, looking to advance the economic well-being of Blacks, particularly our business owners. So happy to be here.
Welcome. Thank you so much, Nicole. Okay, Krina Patel. Krina.
Hi, everyone. Krina. I'm a head of state government affairs at Biogen. We are a Mass headquartered company, one of the top 5 largest biopharmas in the state. And we focus on really devastating neurological diseases such as Alzheimer's, Parkinson's, ALS, diseases with a high failure rate, but high unmet need. We also recently entered into the neuropsychiatry space in developing therapies for postpartum depression and major depressive disorder. We also do some great work in the community and have the first corporate community lab that provides free science education to middle and high school students from low-income and underrepresented communities in Massachusetts. So excited that the HBC is also focused on health equity and workforce issues too. So thank you.
Absolutely. Thank you so much. Okay. Last but not least, Dr. Maisha Rodriguez.
Good afternoon, everyone. Dr. Rodriguez here. It's Cape Verdean, so it's Rodriguez, no problem. So I'm happy to be here, happy to see all of you. I am the new executive director for NAMI Massachusetts. We're an organization that supports, advocates for, provides programming and training for folks with lived experience and their families navigating mental health conditions. We shape and influence a number of different sectors, from education to policy to criminal justice. We have a host of programming that supports both families and peers. My personal kind of investment or interest in training in counseling and psychology has an emphasis on transformative leadership, education, and applied research, grounded in social justice and trauma-informed leadership. And so as I'm looking forward to bringing that lens to my work at NAMI Massachusetts, I look forward to bringing that lens to conversation here as we collaborate throughout the year.
Absolutely. Thank you so much. Well, you're also welcome. Please, a warm welcome to our new members. Thank you for being here and for giving your time. Just to go back to the beginning for a minute, we are joined by our chair, Deb DeVoe. Deb, can you just say a few words?
Sure. Hi, everyone. Delighted to be joining you to meet our new members. And thank you so much for your service, new and continuing members. As Colleen said, I'm Deb DeVoe. I joined the HPC this summer as a new commissioner and chair. Most recently was at Beth Israel Lahey Health as their chief population health officer. And prior to that, spent most of my career at 2 health plans in Massachusetts, Blue Cross Blue Shield and Harvard Pilgrim. Look forward to the meeting. Thank you all.
Thank you so much, Madam Chair. All right, Director Seltz, having dispensed with the introductions, I will now turn it over to you to lead us through the rest of the meeting.
Great. Thank you, Colleen, and good afternoon, everyone. I'm David Seltz, Executive Director at the Health Policy Commission, and just so excited and energized to kick off this 2-year Advisory Council term. Just a truly warm welcome to all of the new members, some of whom I know, some of whom I'm really kind of making a connection for the first time through this opportunity, and just really excited to be able to continue to learn from you and to have your input be really embedded in the work of the Health Policy Commission. We, as Colleen said, just celebrated our 10-year anniversary, and it does feel like just an incredible kind of moment of reflection, but also an opportunity to look to the future and to think about what the next 10 years is going to look like for the Health Policy Commission and for our journey of healthcare reform in Massachusetts, even more broadly. There are members of this advisory council who have been with us for that full 10 years. So double thank you to you. You'll get a special prize at some point for the 10 years of service. And I think if you are one of those members who's been on this advisory council for the full 10 years, you've seen how the membership has changed and evolved over time as well. And I think that's a reflection of the changing and evolving mission of the Health Policy Commission, and in the environment, the current challenges and the current opportunities. And so this current iteration of the Advisory Council is, as noted, just an incredible group of leaders from across all different aspects of healthcare and beyond. I honestly am humbled and honored that you all agreed to be a part of this and to be a part of this group with us, and to give a little bit of your time in public service. So for these meetings, we typically try to kind of keep to 1 or 2 big kind of discussion topical areas. I think we learned over the years but sometimes we'd have an agenda of 7 different things to get to, and we'd always kind of get to like 1.5. And so we are going to try to, we have one big meaty agenda item, but there's a lot to this one. So really much looking forward to the conversation. So the agenda item that I wanted to bring to you all today, if we can move to the next slide, is really around our action plan at the HPC for 2023. And here I'm even really kind of thinking about the first half of the year, kind of January through July. We had a number of really great conversations with this group last year, with other stakeholders at the cost trends hearings. We had our back to in-person cost trends hearings last November. And at the end of the year, had an opportunity for the whole HPC board to also reflect on priorities. And coming out of all of those conversations, we really wanted to put together kind of a prioritized list of the top areas in which the HPC would pursue action, this first part of the year. We also think this is a great opportunity to kind of lay out this work plan in order to partner with the new Healey-Driscoll administration and the new legislature who just started their term as well. So in putting together this plan, and we'll give a couple of caveats. One is this does not even reflect all of the things that we do and are planning to do, we really wanted to highlight some of the areas where we're really kind of leaning forward or putting an emphasis on new activities or new research. I'll also add that I did present this to the HPC board in January and got some great feedback from them. But today I want your feedback and input on this work plan. And so that is really the goal for the next hour of this meeting. So what are the topical areas that we have really identified for priority action this year? You'll see the 6 listed at the bottom of this slide. And I'm going to go through each of them briefly in the next few minutes. I do kind of want to go through all of them so you can kind of see how some may fit together. But then I will stop talking and we can kind of return to this slide and get your feedback, input, questions, and also where you would like to help us. I think this is also a conversation of, if you have particular interest in any of this work, we are enthusiastic about partnering and collaborating with each of you as thought leaders. So on the next slide, the first priority area is to continue to bolster our cost containment agenda. This is obviously core to the Health Policy Commission's work, as it was established with the healthcare cost growth benchmark 10 years ago to moderate the growth in healthcare spending and to enhance affordability for our residents and our businesses that struggle with the high cost of healthcare. We have made good, notable progress on these efforts throughout the 10 years. When we look at our average spending growth rates compared to the United States, Massachusetts has been below the United States just about every year since the HPC and the benchmark were established. However, we do know that the affordability challenges are real and growing. Affordability for residents, which is causing nearly half of Massachusetts adults to forego necessary care because of the cost of the care. The increase in premiums impacting our businesses and employers. And so we identified last year that there was an opportunity to revisit the law and to strengthen some of the levers and tools we have to help the market moderate spending growth. And so our first big activity here is going to be working with the legislature and the Healey Driscoll administration to promote legislative action on some of those recommendations you can see here in kind of I through 3. We think that these 3 things fit together: strengthening the HPC's performance improvement plan process, legislative action to address pricing, and legislative action to ensure that those savings are passed on to consumers and businesses in the form of savings. We know that there have been a number of bills already filed this legislative session which do accomplish many of these goals and recommendations, and so plan to work with the legislature and the administration on this. Absent the kind of legislative agenda, though, we do think that there are a number of other things that we at the HPC can and should be doing on cost growth. One is a reflection that we do need to continually evolve our approach to accountability to the benchmark, specifically in the years that have been so impacted by the pandemic. We saw in 19 to 20 that there was a decrease in healthcare spending in Massachusetts. The next report out will show spending growth between 2020 and 2021, and we expect that to be very high, perhaps even as high as double-digit spending growth. So how we kind of calculate and think about performance of payers and providers underneath the benchmark in a time of pretty extreme disruption and swings in spending is something that we're going to have to focus on. We are going to continue to focus on and work with our MGB, which was the first organization to file and begin implementing a performance improvement plan. We're also going to continue our work in scrutinizing market changes. And here I do want to highlight that there is a requirement as part of the Beth Israel Lahey merger that the HPC conducts a retrospective 5-year review. And so we're coming up on the 5-year next year. So we'll be working on that this year. And continued research on provider price variation and spending growth. On the next slide, so that's number one. I promise I'll move more quickly. So the next agenda item, I think, is kind of needs no introduction in terms of why this is a priority for the Health Policy Commission in addressing the workforce crisis and challenge facing our healthcare system today. So we think this is obviously a critical topic for the Health Policy Commission to convene leaders, workers from across the care continuum to understand what the current challenges are and to begin to identify possible solutions and policy recommendations. To that end, we are about to release a new report on healthcare workforce challenges. This will be coming out probably at the end of March. And in this report, we do look at broad trends of employment kind of from across the system. We also do a deep dive into 3 specific areas: nurses, direct care workers, and behavioral health care workers. So we kind of do a deeper dive on those 3 workforce sectors to understand the unique challenges facing each of those sectors. We think this is such an important topic that we want to bring the community together to talk about this. And so we're going to be holding a special public in-person event at the end of March to convene stakeholders to discuss both our report, but also to even go beyond the report and talk about the current challenges and steps that we can all take together in terms of action. And of course, we continue to support other non-traditional healthcare workers through our investment programs, such as doulas, recovery coaches, community health workers, and think about how we can best innovate our care model and workforce model. The third agenda item, advancing health equity. This is one of those topics that really is embedded in each one of these action items. We have been very intentional about trying to build a health equity lens into all of our work. But given how important this topic is, we wanted to highlight it as its own topic here, again, even though it kind of cuts across many things. So we have a big report coming out this year that is going to be looking at how different health system factors, supply, access, and affordability, perpetuate health disparities. And so we'll be documenting the state of health disparities in Massachusetts, but then trying to really understand the relationship between other domains in terms of how they drive and contribute to unequal health and unequal care. We think that there's opportunities to strengthen our health equity standards in our ACO certification program. We're working with other state agencies to improve data collection on race, ethnicity, language, disability status, et cetera. We think there's opportunities to identify some new investment opportunities that would be specifically focused on reducing disparities. We are really excited to partner and align all of this work with so many public and private stakeholders who are focusing on health equity. And I want to shout out the Health Equity Compact for their leadership on this topic as well. And internally thinking about how we develop a team within the HPC to execute on that work. The fourth topic is around enhancing pharmaceutical transparency. We know that pharmaceutical spending has exceeded the benchmark in many of the recent years. In that year between 19 and 20, where just about in every other part of healthcare, spending went down, spending actually increased in the pharmaceutical space. And so this continues to be an area of focus for our affordability agenda. We do collaborate with MassHealth on their drug pricing review process and have made recommendations to the legislature to expand that to the commercial market. Beyond legislative action, though, we do want to continue our research on different elements of pharmaceutical pricing. So we'll be doing work on comparing pricing to international pricing, examining policies that reduce out-of-pocket burden for patients, and looking more deeply into high outpatient spending. The fifth category here is reducing unnecessary administrative complexity. This is a topic that has been kind of on our agenda for quite some time, but we see that there's a real need and opportunity to accelerate this work this year, given the burden and kind of the headwinds that our providers in particular are facing from a workforce standpoint. If we can do something that would reduce unnecessary administrative burden at this time, that can have a real positive impact on providers, on workers who are burnt out from all of the administrative work. And so we do see a number of opportunities to partner with others to continue to promote standardization, automation, and simplification of a number of administrative processes. And then finally, we have an ambitious research agenda. And so this one admittedly is a little bit of a grab bag, but some of the policy areas that we intend to release papers and reports on this year include telehealth use, which was a report we actually just released at the end of January. We're doing some work on the consolidation of the pediatric market in Massachusetts, implications for capping provider pricing, risk adjustment. We have a whole research agenda related to behavioral health care. So we have a report where we are required by the legislature to do an examination of behavioral health managers. We're going to be updating some work on ED boarding and updating some work on opioid-related hospitalizations. And then finally, we're going to release some research on the kind of state of EMS services in Massachusetts, and are beginning investigations in the role of private equity investments in Massachusetts healthcare. Wow, that is a lot for the next 7 months. So let's return to the slide that has all of these topical areas listed here. And I now am really wanting to open this up to some conversation. And so I guess I'll ask maybe the broadest question, just looking at these 6 areas, does this seem like the right list? Are there glaring absences that you would like to draw our attention to, or ones that you would say, you should definitely double down on one of these? So already seeing some hands raised. Mike, kick us off, 2023.
Great. First of all, thank you to you, Director Seltz and Chair DeVoe, for your continuing leadership and convening such a great group, diverse and very strong leadership throughout the panel. I have a process comment, which is I do think there could be some extra connections into this group before and after the meeting for comments more formally outside the scope of the 90 minutes that we have here today, given the slightly unwieldy nature of the group that we have. And that may be something new to chew on. As to this agenda,
Mike, can you just introduce yourself really quickly?
Oh, I'm sorry. I'm Mike Caljo. I'm Vice President for Government and Regulatory Affairs at Blue Cross Blue Shield of Massachusetts, and have worked with a number of you on this call from time to time. In addition to that process issue, and it's not a concern, it's more of an observation that the HPC traditionally weaves into naturally in the course of your work, and I just want to observe that. I do think that you have the right list. I have 2 observations. One is I do think that there may be some additional scrutiny on prioritization of issues within that list, with particular regard to items requiring urgent action. Workforce challenges certainly comes to mind in terms of a needed deployment of time and energy and resource. And I think for all of these issues, there's probably a short-term set of solutions and longer-term policy guidelines. And then my other observation is I think it would be good to refine back just a little bit on core items central to the mission of the organization as it evolves, right? Not just around cost and affordability, but a wider set. And those that are nice to haves, and maybe if we didn't quite get there in a short-term basis, we keep them on the list, but there's not as much urgency towards the action. I think that building toward those issues, stakeholders will have a different set of items that fall into that grouping. But I think weaving through that to creating a more fabric sense of urgency might be a great idea, and take this away from being a more observational document to being a more driving towards relief or solutions document. But all good stuff and a great group of issues on this list.
Great. Thank you, Mike. And to your first question, I mean, we absolutely do envision that this is a dialogue that continues outside of these meetings. And really, you know, these are only 90-minute meetings. And so very much welcome any members' input, feedback. Reach out to Colleen and I. We're happy to dive, you know, much deeper on these. I think, you know, you raised some really good points, Mike. And I do think putting this together, you know, putting a priority list together is always a struggle because it starts to, you know, get a little unwieldy in terms of, wow, we have so many priorities. I do think, so your comments are well taken. And I do think as we kind of evolve this document and, you know, refine it over time, having something a little bit more clear about like what are the right now things versus maybe the next 6-month things versus the next 12-month things, and trying to put a little bit of a, you know, kind of a timeline of urgency even among these as we present this. I think that's a good suggestion. All right, JD.
Thanks, David. JD Cheslav, President and CEO of the Massachusetts Business Roundtable. Just to echo a couple of things Mike said and go a little deeper on one. I agree that the new additions to the group are outstanding. We are a significantly better body now than we were last year. So I acknowledge and thank you for so thoughtfully adding some great perspectives to our group. Regarding the list, totally agree. I think it's the right list. I think the value of a diverse group like this is everyone's going to want to prioritize something else on the list. For the roundtable, it's definitely 2 and 3, and those are both very much at the top of our agenda. And I do want to put a pin in the workforce issue and go one level deeper than what Mike said, which is, you know, as we think about the urgency of this issue, and you're going to release your report in March, I hope that you would use us and activate us in terms of implementing recommendations. You know, it could be, we are an advisory group. I would like to also be action oriented, particularly around workforce. So feel free to call on us, use us as a resource, particularly on that issue. It is extremely urgent, as Mike said, and one that we would love to be helpful with.
Well, I will absolutely take you up on that offer, JD. And just to spend maybe a minute more on the report and the event, we have scheduled the event. Colleen will share a little bit more details about the event, which will be at the end of March. I think we already know and acknowledge that event is not going to be the end of the conversation. That is not going to be the event where we all find the one solution to our workforce challenges and go home. I think it's going to be a long-term conversation, and the solutions are going to need to be long-term, but the urgency is there to really identify what some of those solutions are right now. And so I do think that this is going to be an agenda item that evolves over time, but is going to be a long-term challenge for all of us. So look forward to partnering with you on that. I'm going to move to one of our new advisory council members, Dr. Callahan.
Thank you. First of all, I want to thank you again for allowing me in this conversation, because I, for one, would not have listed these the way you have. First of all, I would have made 2 and 5 exactly the same. It is because of unnecessary administrative complexity that people are not going into my field. It is why people are retiring from my field. So and those two, I think really there's an overlap. My concern with always itemizing is the siloed effect of that, thinking that we can address one without the other. And so that's really my 2 cents. I want to do a little bit of listening because it was my first meeting, right square in the face, because I deal with this every day. That the administrative complexity has nothing to do with patient care and has everything to do with why our workforce is dwindling. So I would love to participate in any way I can in working with that. Other thing I should mention, you've already gotten my credentials or so forth, but I'm also a co-founder of a nonprofit that really reacted to the fact that the way in which we were doing medicine is not creating wellness. So I have a nonprofit, the Wellness Collaborative, really started by 3 healthcare providers that realized that if we continued in this basically, if we continue to sustain a system that's not working, that we are equally at blame when our patients are not well. And so part of it is not siloing off as we do. It is a collaborative effort, interdisciplinary, and it's an educational nonprofit. So I would absolutely love to participate more in seeing what we can do about 2 and 5 and looking at them as one issue.
That's great. That's excellent. And I think you heard me even kind of make the connection as I was presenting on admin complexity, that this is part of the workforce saying, hey, let's combine it and then we're down to 5. That sounds great to me. Love to get this list even punchier. Chris Schuster, welcome back.
Oh, thanks. Hi, I'm Chris Schuster, the president and CEO of Emerson Health in Concord. And I think this is a really terrific list. And I would just underscore that none of this gets done if we don't really address the workforce issue. And it's really a 2-pronged approach, right? Short term, we need, something more than bubble gum and duct tape and agency staff to fill our staffing holes. And longer term, we need to work on the pipeline and how we can really address the pipeline issue so that in 5, 10, 15 years, we don't continue to have these issues. Because what isn't clearly here, but is a big issue, is the access to care. We have really long wait times in just about every system to get folks in to see a physician or an advanced practice provider. And this is, I've watched through the pandemic, it gets worse and worse. And then that sort of drives that, okay, if that's the problem, what's the solution? We should really look at extenders like telehealth, hospital at home, and how does that help us to mitigate some of those access issues? And then finally, near and dear to my heart, because I see it every day in my emergency room, as well as my colleagues across the Commonwealth, is behavioral health, especially for our pediatric population. So I don't want them to fall by the wayside. And that all drives back to where we started, workforce, right? If we had more people in the workforce, we'd have less access issues, more people to care for our behavioral health patients. Otherwise, I think the list is spot on.
Thank you. I think you're really, some of these comments are really highlighting how interconnected these are and kind of putting them on a list. Maybe I need like more of like a web of how all of these things interconnect with each other. And Chris, I think you're absolutely right in terms of how we need to think about the workforce challenge in terms of short-term, long-term, innovating our care teams. And the fact that it's creating these, as you said, these access challenges. And it's, the news of the week was on the primary care front, but, the news of last week was on behavioral health workers and people not being able to get personal care attendants. It's throughout the system, and then creates, bottlenecks of care that lead to poor health outcomes, candidly. And so this is, thank you for underscoring the importance. I'll leave it at that. Colin, welcome back.
Thank you so much. Yeah, this is I think this is a great list. And also, yes, welcome to our new members. Some folks that I've worked with before who I'm excited to work with again, and some new folks I'm excited to get to know. I think this is really good. Just a couple of thoughts. You just mentioned PCAs, but under the workforce point, wanted to really underscore that. We are standing with 1199. We've already reached out to the new leadership at EOHS asking for an immediate emergency $20 an hour rate for PCAs, because it is dire out there. People are really struggling to find PCAs. When fast food can outbid, is paying more than PCA wages, that's hardly surprising. I think on the pharmaceutical pricing piece, there's some real opportunity for innovation here in terms of methodology opening up. And I think that the HPC together with Mass Health could play a really key role in advancing that. And then lastly, I think having advancing health equity on here is a terrific goal. And we'd, of course, be very happy to work with HPC to ensure that disability it gets factored into that in an effective way. One slightly wonky question, which feel free to answer offline. You mentioned in here about strengthening the standards for ACOs in terms of health equity, and I'm curious how that interfaces with the reprocurement of the ACO program that Mass Health just did.
Thank you for all of those comments. I'll address the last one very briefly. So we at the HPC administer a certification program for accountable care organizations, where we are really assessing their capabilities across a number of domains, not just for their work with the Medicaid population, but for their work with the commercial population and for their work with the Medicare population. So we really try to assess them kind of on an all-payer basis of what they are putting in place to drive towards more accountable and patient-centered care. So it is a requirement of Mass Health that anyone who's participating in the Mass Health ACO program needs to be certified by the HPC. So it is separate, but it is a requirement. And so given that, we do have an opportunity. This year is the year where we get, it's a 2-year certification. So we're up for revising our standards this year. In the last certification round, we asked a few questions about what ACOs were doing in terms of data, health equity data collection, designing programs. It was a little bit more of like asking what they're up to. And I think that there's an opportunity to move beyond that and to put some perhaps stricter standards in place of what our expectations of ACOs. And really the goal is to try to just kind of continue to push forward on some of these areas. So that's a little bit of background for everyone on the ACO program and that opportunity. And I will say that is an ongoing process and will also be one in which we're going to be soliciting public input from a number of stakeholders as we develop those standards. I did get a question in the chat that I wanted to address as well, which was around the HPC's work on DON, determination of need, expansions, and evaluating the impacts of those expansions and the relationship of both expansions and closures on health equity topics. I would say that is absolutely continues to be a part of our agenda. We did last year submit comment to the determination of need program on the MGB proposed expansions that highlighted some of those concerns. And in addition, we are, as part of this work on the pediatric consolidation, we're looking at where those closures have taken place, impacting what types of populations. And then finally, I'll just add, as part of the health disparities report, where I talked about we're looking at supply and access and health disparities, there's going to be a part of that report that is actually cataloging all of the essential service closures we've had over the last, I think, 10 years, and trying to really kind of analyze and characterize where have we lost access and how, who has been most impacted by that. And so I think the changing and evolving market and our role in providing objective analysis of this will continue to be a priority. All right, Jake, I'd love to hear from you.
Yeah, thanks, David. Yeah, Jake Krilovich with the Home Care Alliance of Massachusetts. Good to be here.
I feel like I have a similar thread to everyone else where a lot of these are interconnected. I don't think that we can solve the cost containment problem without addressing the workforce issue. And I think in the context of home health, home care, and hospice, I feel like it's two-pronged, right? You've got the costs of simply recruiting and finding the workforce and all of the costs that go along with that, but also the costs of the seniors, the elders who are awaiting services. We have, I think, 4,000 older adults in the EOEA home care program that are awaiting services. There are just hundreds of referrals on a daily basis that home care agencies and home health agencies are turning down from hospital discharges. I think over 30% of authorized hours for skilled pediatric care to medically complex kids in the home are going unfilled. And all of those just eventually lead to pushing these patients into a higher cost setting. And then the last thing I'd add is I definitely look forward to shedding the light on the role of home health and serving Mass Health members with severe mental and behavioral health needs. I think there are thousands of Mass Health members receiving these services in the home. I think it's powerful. I think it keeps them at home and stable. And I think we look forward to talking about it.
Thanks, Jake. And maybe just as a follow-up question for you, when in thinking about the workforce that you represent, is the current challenge a recruitment challenge? Is it a retention challenge? A little bit of column A, a little bit of column B. If you had to put a finger on the scale there, where would you characterize it?
Yeah, I think it's both. And I think that what we see, it has to do with like Colin had said, PCAs, it's similar workforce competing against retail. I think as it relates to the nursing workforce, competing against facility-based opportunities. And there again, it's a wage, it's a compensation, it's a reimbursement issue, but it's also having to do with historical challenges in recruiting people into the field and into home and community-based settings, just inherent biases in our curriculums that push people to facilities, things like that. So it's two-pronged.
Thanks, Jake. Look forward to talking more about that. As I mentioned with the workforce report, we did a little bit of a deeper dive on behavioral healthcare workers, nursing, and direct care workers, and tried to kind of identify some of the unique challenges there. And wages and wage competition was something we definitely heard in the in many of these sectors. And we're kind of also thinking about kind of an employment life cycle. So from recruitment to education to retention and advancement, where are there solutions kind of across that continuum that we may want to emphasize? Liz, welcome back. It's great to see you.
It's great to see all of you. Thank you for having me back. For folks who haven't heard me speak before, I'm the director of the Springfield Food Policy Council, which makes me sort of an odd addition, except that all of my work is framed around a policy systems and environmental change approach, not just in Springfield. I serve on Mass Public Health Association's policy committee and on the Massachusetts Food System Collaborative. And it's important for me to share that because I work across the state and equity is in everything we do. I don't, from my vantage point, think number 3 should be a bullet. I think it should be the overlay, and I think we need to be bold and name it as racial equity. During COVID, one of COVID deaths, Black people died disproportionately at greater numbers than everyone. And if you compared us to white people, about 1 in every 1,000 Black people in the US died, and about 1 in every 2,100 white people died. The numbers are even more disproportionate in Massachusetts, and COVID was this thing that is ongoing, but it illuminated the disparities. The National Institute of Health, I know I'm preaching to the choir, has finally come out and told us exactly what the comorbidities were that people died of: hypertension, cardiovascular disease, and diabetes. And when you look at communities of color, we are disproportionately impacted by that. All of those things bolster cost. We know who's showing up in emergency rooms because they're not getting regular care. We know who's not in the workforce in the places that we really need them to be, so that people are talking to people in their own languages, from their own cultural backgrounds, from their own communities. Black people and other people of color are disproportionately impacted by increased pharmaceutical pricing cost. And, you know, when we talk about topics of actionable research, when we look at telehealth, we'll see that communities of color were not served as well as other communities. So if we were looking at all of these things through a health equity lens from the perspective of race, it could drive what we learn in a different way. And to put it simply, we all do better when we all do better. So when we design for those that are the hardest to serve, the hardest to reach, the hardest to engage, we're going to come up with strategies that are going to benefit all of us. So I encourage you to think about that from that vantage point. And I'm asking a lot. I'm asking you to be really bold and brave. But if COVID didn't inspire us to do that, nothing will. We knew before COVID who was the sickest and the most marginalized and who had the shortest lifespans. We've also learned that food is medicine. And so I'm struck by, I don't know where that's embedded, but imagine if I lived in a neighborhood that didn't have 10 McDonald's and no grocery store within a mile and a half of my house, what the health outcomes of my neighbors might be. I appreciate your listening.
Thank you so much. And we like to be bold. We can be bold. Let's be bold. Very much thank you for that encouragement. You know, in addition to all of the stats that you have at your fingertips, you know, we also, when we look, I mentioned that stat about almost 50% of Massachusetts residents foregoing necessary care due to the cost of care or you know, splitting pills. When you do those same survey results, Black and other people of color, those rates are much higher. So in addition to everything, the affordability challenges, the access challenges, everything is exacerbated. And I do, you can hold us to account, Liz. I hope that we will really execute on the vision of putting equity into all of this work and into all of our research. Donna, welcome back. How are you?
Thank you, David. Fine, and welcome to all of the new members, and greetings to those of you with whom I earlier served. Thank you very much for producing this list, David and Colleen and others at the commission. Building on the comments of others, addressing the healthcare workforce challenges is absolutely dependent on reducing unnecessary administrative complexity. It is acute in behavioral health workforce challenges because it is not simply trying to find more people who will come into the field at all levels and who will be educated to qualify as licensed professionals, but that more than half of our licensed professionals are presently sitting out of providing services that are reimbursed by insurance. This closes off for many people who cannot afford to take the risk of seeing someone without an ability to use their insurance. Closes off more than half of the licensed psychologists, social workers, and psychiatrists. And we can't solve the workforce problem without finding a way to address those people sitting out of serving most insured people and finding ways to entice them to rejoin the workforce at the same time that we work on all of the other strategies, some of which have been recounted here for building additional capacity in the workforce. With regard to health equity, solving equity for many of the people who have are still suffering not only lack of access, but access to appropriate and high quality care that meets standards. If we do not solve the cultural responsiveness for the workforce, we will not be able to truly fix the health equity issue. We have a long way to go, and many of us in behavioral health and primary care have talked about this. The primary care workforce has done better historically than the behavioral health workforce at addressing cultural responsiveness. But we definitely, as we're trying to create incentives, whether those are, training programs, scholarships, loan forgiveness, and pipeline enhancements, we have to dedicate ourselves to diversifying the behavioral health workforce. Thank you.
Thank you. And I'm so glad you brought up that linkage and that connection. I think the idea of needing to emphasize diversifying our healthcare workforce at the same time that we're kind of thinking of solutions to the current crisis, I think is absolutely essential. It will be part of our report and our recommendations that we're going to be putting forward. And I think want to incorporate that into the conversation at the workforce event as well. And open to hearing from all of you if there's particular panelists or speakers or thought leaders that you want to recommend that we think about including in that conversation at the event at the end of March to really drive that home and to think about a healthcare workforce that looks like the patients and the communities that they serve. So thank you for that comment. Dr. Dunlap.
So Ron Dunlap, past president of the Massachusetts Medical Society, cardiologist, biomedical engineer with a long-term interest in both healthcare workforce diversity and healthcare access for underserved populations, as well as the use of technology. So one of the things I've been trying to concentrate on this year, and that David knows this, is to start to try to gather data from across the whole Massachusetts healthcare scene to see exactly how diverse our workforce is. Because I think that the top three things there, health equity is not an isolated phenomenon. It's closely related to workforce issues, and it then feeds back on high costs because of underserved patients. I think that we have to start looking at where we are. We have different communities, urban communities with academic centers, rural communities that are vastly different. Some providers don't ever see a person of color, for instance, in this state, when you look at where the physicians are and where the patients are. So I think this has been a long-term problem. When on the Commission to End Healthcare Disparities, we were back to grade school and we started to look at where the attrition was in terms of pipeline issues and bringing forth educated people who could become physicians. So I think that this is closely related to economics and general welfare in the community. And I think that it really requires getting that data first. The AMA has 10 years of data. They know exactly who applied to medical school, what the race was, where they went to school, where they went to train, where they went after training and so forth. But you have to pay to get that data. And I'm looking to try to get that data to be made public this year. But I think we also have a lot of data in Massachusetts, which I hope the HPC would be helpful in gathering so we could really look at this. The other thing I wanted to do is make sure that we start to look at technology and quality. It's one thing to just have telehealth, but we also have to look at what is the quality of the healthcare delivered and how does that compare to an office visit, for instance, for a given type of disease. So I think that's an incredibly important thing that I don't think anybody's really done yet. Thank you.
Thank you, Dr. Dunlap. And I just wanted to share a few thoughts on the data collection piece here as well. Agree with your sentiments and do think that there are opportunities for us to enrich our understanding of the healthcare workforce in Massachusetts. We've been in touch with the new executive director of the Center for Health Information and Analysis, someone known to many of you, Lauren Peters. And as part of our first initial conversations, we've been talking about different ways that CHEA can help advance our data, our data infrastructure and resources to be able to help identify, measure, and understand some of the trends and drivers across the healthcare system. But in particular, one of the areas that we were talking with them about is expanding their annual survey, which they typically have a household survey that they do every year but to do one that's actually specifically focused on the healthcare workforce in Massachusetts, so that we're collecting on an annual or every other year basis information that can help us be able to baseline, identify trends on a number of the different dynamics and variables that you mentioned. And so continuing to work with CHIA on that, and hopefully they'll have an announcement soon about their action steps and commitments. But a great opportunity with Lauren at the helm to work together with that agency to really identify the gaps and make a plan to fill them. John Hurst, welcome back. How are you?
Very good, David. Thank you for having me back. And it wouldn't be a first meeting if I didn't raise small businesses. I'm not exactly sure where small businesses fit in those 6 bullets. I suppose under number 1, but look, I would hope it would fall under the HPC's priorities and purview to take a look at what's happening with small business costs. Something that came out of the Governor's Merged Market Advisory Council study last year showed a shocking drop of 400,000 lives out of the merged market of small business lives. I mean, that's a crisis, that's a scandal really that nobody's talking about. And is that created by discrimination under the markets, under the law, you know, of risk pools, of mandated benefits under state law versus federal law? All these things, when you talk about containing costs, the HPC needs to be looking closely at whether costs are being fairly distributed amongst all different types of consumers. And I would think, David, that needs to be, if not a 7th bullet, it needs to be a very strong subset of one of these 6. Thank you.
Thank you, John. And I think that in my mind, that does fit under number 1, but I think we can be more explicit about, you know, what we plan to prioritize in that area. So take that feedback. Zach Stanley, welcome.
Thanks, David. I wanted to just follow on what John's saying and some others. I think the HPC is to be commended about their focus on out-of-pocket costs across the system and how that impacts, you know, patients' ability to access care. I think that's particularly necessary when it becomes time to study around access to pharmaceuticals. There's a lot of data that's been out recently. You know, yesterday, you know, as cancer care drug out-of-pocket costs go up, 59% of people abandon or never pick up their medicine. So this is having a real impact on patient health across the system. And then keying in a little bit on the data piece I was talking in before. I know this is something we've talked about a little bit, but thinking about data as it relates to pharmaceuticals and how to properly measure that in reports and studies and how that leads to legislative and other recommendations. You know, I think pharmaceutical spend is probably unique in all the reports, and that it's measured in 2 different ways, both in gross and net. And that's confusing, if nothing else, and probably leads to inaccurate conclusions at the end of the day. So we'd look forward to talking with you more and CHIA certainly about how to capture that data accurately. I think the last thing I'd say is probably, you know, across the board, looking at national trends and how that measures up to Massachusetts. I know that's done in certain areas, but I think it probably can be used more broadly to see whether Massachusetts is out of line, in line, or doing better. And whether or not that means our data's accurate, inaccurate, or whether there's some sort of outliers going on.
Thank you, Zach. And just quickly, can you just introduce yourself and your org? Sorry.
Oh, I'm sorry. Zach Stanley, Chief of Corporate Affairs at MassBio.
Great. Thank you, Zach. Yeah, look forward to working with you and your organization on the data piece in particular and how we can continue to refine that. Laura, welcome. And I just before you jump off, Laura, I just want to say we'll have about 8 minutes left for comments and questions. This has just been so incredibly valuable to hear your feedback and to hear your reflections on this work plan and the interrelated nature of this work, and your affirmation that, you know, generally these are the right right topical areas. So if you do want to share some thoughts, please raise your hand in these waning few minutes. But Laura, would love to hear from you.
David, thank you very much. And thank you for the continued work of the Health Policy Commission. You know, again, I think the role of the Health Policy Commission is really to drive home this notion of we need to contain healthcare costs. And I think John touched upon the need to do this for employers and consumers in the Commonwealth. We have a lot of challenges in the state, and certainly healthcare costs are one of them. When I hear proposals around cost sharing and to limit cost sharing because you're denied access to drugs, I find that very cynical. We need to get to the root cause of the drivers of healthcare costs. We know what they are. We know the pricing of prescription drugs are one of the key drivers. To try to mask that by then having a conversation about cost sharing, I think is very disingenuous to the consumer. And while it shields them at the pharmacy counter, maybe they're not paying that cost sharing portion, they're going to absorb that in their premiums. So I think a priority, and you have it here, is we really need to drill down on pharmacy costs. I think we've had some success at Mass Health. I think we need to hold the pharmaceutical industry accountable for rising drug costs. We're going to see this now in vaccines, where there are talk of, you know, quadrupling the price of vaccines once the public health emergency is over. Mass Health has been successful in those negotiations. The commercial side of the house, we need to have those same types of levers to use, and we need to hold the pharmaceutical industry accountable at the Health Policy Commission. When the Health Policy Commission was first created, the health plans and providers were asked to come to the table to talk about what are the drivers of healthcare cost and to be held accountable. We never opposed being at the table. So what I would ask MassBio and the pharma industry to also agree to come to the table and talk about healthcare cost. So I hate to be the skunk at the lawn party. This has been a great conversation, but we are sort of getting away from our mission, which is containing healthcare costs. We've just been through a terrible public health emergency. I thank our frontline workers for everything they've done on COVID. I know there were stressors on the system, but we need to get back to some of our roots here. When you look at the bills that have been filed for this session, they're very alarming. I sat with somebody yesterday who said to me, well, what about cost containment? And I said, a lot of folks around this table aren't really caring about that. They're kind of going for the gusto, and they want to limit a plan's ability to contain healthcare cost in any way they can. And I find that really disingenuous. And I think we all need to come to the table with solutions, and it's bigger than just administrative complexity. So thanks very much. And I'm back.
Thank you, Laura. And thank you for, you know, continuing to put an emphasis on the cost containment and affordability issues. Number one on our list. David Mattiotto, welcome back.
Thank you, David, and thank you for having me back. My name's David Mattiotto. I'm Executive Director of the Mass Association of Behavioral Health Systems, and we represent the inpatient, psychiatric, and substance use facilities. And welcome to all the new members. I'll be very brief because a lot of the points have already been made. I'm very, very happy that number 2, addressing the workforce challenges, is on the agenda. It's by far the biggest issue for behavioral health inpatient providers, in that we have on a given day 600 to 600 people boarding in emergency rooms. At the same time, we have 600 to 700 empty beds because we can't find the staff. I also think that the workforce has led to patient flow issues. We have problems getting transportation for patients from one facility to another, or even to doctor's appointments when they need for medical care. They have to wait for days for ambulances, so it's impacting that. And then the patient flow in terms of discharging, whether it's to a residence, to a state facility, or to a nursing home, there's severe backups. We have patients waiting incredibly over a year to get discharged in certain circumstances. So it's a big problem. I'm glad we're going to be working on addressing the health workforce challenges. And ironically, just to add one more quick point, We're losing a lot of the inpatient facilities. We're losing a lot of people to staff to telemedicine. It's easier for them. They can make more money working in telemedicine, particularly social workers. It's impacting our inpatient and partial hospital situation. We can't find social workers because they want to go work with telemedicine. So a lot of people, I didn't realize that till recently, but just thought I'd put it out there. So thank you for having number 2 on this agenda.
Thank you, David, and thank you for that observation and insight. And I just want to reflect a comment from the chat here as well that I think is important when we talk about some of these workforce challenges. Many of these did predate the pandemic, and were trends that were there beforehand and were exacerbated by this pandemic and the situation now. And so it's a big challenge. It's not just the pandemic, and will require our collective action and will. Also, just wanted to address another question I received from Juan Lapera, who just has a little shaky Wi-Fi, but was participating in the conversation and wanted to highlight an opportunity to think about a health equity performance index, some way to be able to track quantitatively if we're improving, and to track our state's performance, not unlike the benchmark. And I think that that's just a really exciting idea. I think it's an idea that we would love to work with others to try to advance. And I think having, measurable goals can really help focus action. And so love that suggestion, and we'll follow up with you on that. Amy, would you like to have the final word on this conversation?
I'm happy to chime in, whether it's the final word or not. Although I'll always say that. Hi, everyone. I'm Amy Rosenthal. I work at Healthcare for All. Nice to see you all. These priorities align almost identically and very consistently with what Healthcare for All is focused on. We hear on our helpline all the time about the inability for people to be able to get appointments right now. So pleased that the workforce challenge is really highlighted. And we know from talking to our friends in hospitals that obviously that this is an issue as well as in outpatient settings. So just want to put out there that we're glad that that is there and will need immediate attention. I would say, as we've just finished celebrating the 10-year anniversary of the Health Policy Commission, that we do think it is time to, kind of revisit and get grounded in the cost containment activities. And, we look at it across the board of all the drivers that are bringing up costs for people in the system. And that includes thinking about pharmaceuticals. It includes the direct costs that consumers are experiencing with their insurers. And it's also thinking about high cost hospitals. And so we do think that that's a longer process of thinking about what provisions and what new opportunities there are for the Health Policy Commission moving forward, and recognize that that may be a discussion that we have over the next year or two, but do think it needs to be had so that we are focusing on it. And the reason that we are so focused on affordability for people is because we do believe it is inherently a health equity and racial justice issue. And I thank Liz for all of her comments about how she framed up issues around affordability and race in particular. And so do just want to echo that, really drive that home. And I would say that consumers that we hear from, they need us to be focusing on these system costs, and they need the immediate help right now in terms of bringing down the costs for their prescription drugs that they are dealing with in the immediate future, and tomorrow when they're going to pick up their meds. So I do just want to say that I'm glad behavioral health continues to be on the list and making sure that we're thinking about it. So thank you for all the work. I know it's a lot and appreciate it.
Thank you, Amy, and look forward to working together on many of these shared priorities. Matt, final word?
Yeah, at the risk of robbing Amy of the final word status, my good friend. So I'm going to kind of echo a little bit, but with a slightly different frame, some of the comments of others around affordability. And I think certainly we can argue, or anyone can argue, I think we can all agree that the workforce challenges are acute and urgent and, you know, not new, but certainly of a much different degree and intensity today than they ever have been. And so that certainly deserves to be treated as such on the priority list here. But I would say the cost containment imperative here, which I would agree with Laura, really needs to be at the core of the mission of the HPC, as it always has been. And while this is, again, also not a new dynamic, it is tracking similarly to the workforce challenges, where its intensity, its rising intensity is worthy of that having the same kind of urgency as the workforce challenges. So I appreciate, David, the fact that that continues to be number one on the list. And as others have said, all of these priorities are interrelated in very complex ways, so we can't afford to leave any of them aside. But we need to continue to really put our shoulder into cost containment activities. They can't in any way lose that core focus of the agency going forward. So thank you again, and thank you for the work of your team. Really excellent work.
Thank you, Matt. And I just absolutely agree. And I think this list is really, this work plan is really intended not as an either or, that we can only do one thing and not the other. It's really a yes and. And so how can we, yes, need to address and work through some of the workforce challenges, but not lose our sight on affordability and all of these issues connected. So it's a yes and list as far as I'm concerned. I just want to close this discussion just by again saying thank you to the advisory council members for agreeing to be a part of this group. I think for the new members, you can see that this is a pretty free-flowing conversation and an opportunity to, you know, inspire us and to challenge us, and we welcome that. So look forward to the work together over the next 2 years. And with that, I will turn it back over to Colleen to close us out.
All right, thank you, Director Seltz. So just a few more slides here. But before I start, a video recording of this meeting will be posted to our YouTube channel. And of course, make sure you hit the subscribe button on the YouTube channel. And these slides that you're seeing are already posted on our website proper and available for you now. So on this next slide, lots coming up for the first quarter of 2023. We'll have 5 more public meetings before the end of the winter, long winter here at the HPC. All these meetings, of course, will be live streamed and closed captioned like our advisory council meetings. On this slide, I'll just point out quickly our Office of Patient Protection public hearing in particular here. We'll be holding a hearing on the changes required to OPP's health insurance consumer protection regulation. That is coming up on March 2nd. And then on the next slide, a preview of what's coming at our committee meetings. I'm just highlighting this here now. David mentioned all of these topics. We've discussed them all today, but we're already digging deep into the work plan for 2023. Topics that may be of interest to you include ambulance utilization and payment rates in Massachusetts, pharmaceutical drug pricing, new research, reducing administrative complexity work, health equity standards for ACOs. We'll be hearing from Mass Health. So that's all coming up at our committee meetings on February 15th, a week from today. On the next slide, very exciting, our annual benchmark hearing. This is our annual hearing on the healthcare cost growth benchmark. This is coming up on March 15th. You know what this is. It's a hearing to solicit and receive testimony on setting the benchmark for next year. So the 2024 benchmark. This is the fundamental mechanism for the state's cost containment efforts, and also a really unique event because we co-host it with the legislature's Joint Committee on Healthcare Financing. We're asking you all, our stakeholders, our market participants, our members of the public, please sign up in advance to testify on where we should set next year's benchmark. We're going to be back in person this year. We're going to be at Gardner Auditorium at the State House. Again, signing up in advance really helps us, and as soon as possible too. Reach out to Ash Conter on our team. Her email's at the bottom of this slide. Hasten to add, Ash also works with the advisory council, so a great point of contact here for you and your team. Again, her email address is at the bottom. Sign up. You can let us know who's coming from your organization later, but we're just great to have the list going. After the hearing, and also just to note, we will accept written testimony as well, but the benchmark itself after the hearing will be set at the next meeting of the HPC's board. That's April 12th. The default rate, 3.6%. which would be equal to PGSP that was recently set at the consensus revenue hearing, but the board can determine an adjustment is reasonably warranted, and they can set it to any amount for this year. And again, we're talking about setting it for 2024. Then finally, on the events front, we've talked a lot about this, workforce. We're hosting a special event solely focused on the workforce crisis. This is going to be March 29th. Save the date. We're sending a special invitation to all of our advisory council members. Agenda, participants, TBD, but really just trying to use our convener role here to promote the much needed action and alignment that we talked about today on workforce, and also as well to release the report that, as David said, that we've been working on. The next slide, just a calendar. This is our public meeting calendar. We update this all the time. We're adding meetings all the time. This is on our website, mass.gov/HPC. And then finally, last but not least, I just want to talk about listservs. I know this is everyone's favorite topic, but if you want to be up to date on all of these events and more, really encourage folks to sign up for our 2 newsletters. The main one, HPC News and Events, is hpcinfo@mass.gov. And then if you're interested in receiving our Transforming Care newsletter, which is absolutely incredible, you can sign up for that as well. If you go to our website and go to the slides and you click on either one of these graphics, it'll open up an email where you can sign up directly. That's the easiest way to do it. And then the info's on this screen as well. And I think that's it. At 1:30 exactly, the next meeting of the Advisory Council will be May 24th. And we'll see you all then. David Seltz, close us out.
Thank you. Have a great week, everyone.